And now it is my distinct pleasure again to introduce Mr. Joel Yuhas. And so you're getting amazing flavor, right? You've got a guy who's running a physician network, ambulatory network, really trying to build a new system of care to take risk. You've got a health plan person, and you've got a hospital guy. So Joel runs a hospital. I'm honored to actually be on his board. He lets me occasionally kind of hear what they're doing, and it's really exciting stuff that they're working on down there in an area of Long Beach where there's a huge amount of need and not a lot of people who are commercial. And so Joel is a fantastic human being. I met him when he was a chief operating officer at St. Mary, and then you went to Ireland, right, and ran healthcare in Ireland for a while and came back to the U.S. So great guy. I want to introduce Joel, and I'm going to try, I think Sarita's got a few slides you might have to click past, but you'll be in good shape.
This one? Yep. There we go. So it's great to be here with you this evening. Thank you, Alan, for inviting me, and Esther and Dr. Torrens as well. So I, like Roland, am not a population health management expert. I am an ordinary hospital CEO who is from Ohio, who is absolutely passionate about the minions. And I'm sorry that I interrupted my colleague for my ringtone, because I absolutely love them. I've been back in the United States just over a year now, and so like every hospital CEO, I'm trying to figure all this out. And I have a competitive disadvantage, probably, because I've lived the last 6 years in Europe managing the University of Pittsburgh Medical Center's international division of hospitals and cancer centers for them. So I was parked in Ireland and loved it, and helped also manage our hospital in Italy and cancer centers in the UK and build a network in Russia and Kazakhstan. So there's a lot of cool things that I'm really fortunate to have experienced in my time with UPMC, but I was glad to come home. One of the cool things that I drew on from my 6 years abroad was just the exposure to just a different way of doing things. And every country thinks that they've got, every country except for Kazakhstan, thinks that they've got, something that they're really proud of, and in some cases, many westernized countries feel that their healthcare system is the best, and we feel that sometimes ourselves. But what I liked about the experience is that UPMC sent me over there to test out things and try things and spend money and lose money, but learn and see if we could redeploy new ideas and innovation back in a domestic setting back in the United States. And so as I left and came home to my other home in Long Beach, California, was thrilled to come back to St. Mary and Dignity Health, which is the 5th largest U.S. not-for-profit faith-based system in the States. So coming back, we hired recently, these are fresh off the press, and I had this presentation just a week ago before going to China, where Dignity Health is building an international division. I'm helping them do that, fortunately. But a week before leaving, we got a summary of some consulting work that we engaged with a company called Evolent. And Evolent is, funny how things come full circle, never burn a bridge, a UPMC product. We own a bit of it. And they help health systems and hospitals decide if they should enter the game of developing their own health plans and develop innovative population health management strategies. And so I had worked with Evolent when I was at UPMC, and now I'm working with them again. But I wanted to give you just a kind of a summary of what their findings were. Alan mentioned that healthcare is very much a local product, and true to speak, we were interested, Dignity was interested in finding out if we have 47 hospitals covering 3 states, essentially mostly in California, where we've got 6 of our 8 markets, are there things that are so common that we can draw from, that we can share and learn and centralize one methodology for managing population health? And like I said, we're learning, we're trying to figure things out. We're not the experts in it. I don't know of anybody in our system who's actually an expert in it either, even though we have an office for it. But what we found out from our consultants were that your execution strategy is market specific. As much as we want to try and figure out a common strategy, and as much as we want to try and centralize and care coordinate everything the same way, and create care standardization models that go across our entire system of hospitals, it's not probably feasible. Because each market's different, and a Southern California market looks different than some of our Northern California markets. It looks very different than Arizona and Las Vegas as well. So they went on to say, not only is your execution strategy market specific, but we think that if you adopt some really tight care coordination and UR processes, that we can actually get regions like Southern California, where there is a high concentration of Medi-Cal recipients, that we can get you modeled down to a net neutral financial impact if you invest in a population health strategy. And I can tell you, there's 5 other colleagues of mine who are sitting at the table listening to this presentation saying, I don't think so. We haven't figured that out quite yet, but we know, we know, as Sarita mentioned, that the Medicaid program reimburses just a fraction of your costs. But they really felt that they could help us get there, so we were along for the journey. But we also heard from them, and I do believe this one, that there are opportunities on the fee-for-service side. Many hospitals are focused, as are we, and a lot has changed in the time that I've been gone and come back, on managing large groups of patient lives. And we have capitation strategies at most all of our hospitals, trying to work with large physician groups at managing groups of lives as efficiently as we can. And so we think that there is a fee-for-service impact that's part of our strategy as well. And then as a $17 billion organization, that Dignity is, when they saw that Evolent promised them that there's probably a $2.2 billion opportunity, they were really excited about that, and that got us engaging them even more deeply. Last thing on the overview piece is that, there is so much in Alan's slide that showed all the different impacts to healthcare, the influences on healthcare. Exactly what Evelyn said, you might as well be an Evolent consultant, because they said that there's continual price changes, there's a decreasing reimbursement trends, there's the influence of trying to reduce hospital cost structure so we can create more value, there's lots of competition in our market, and there is an overall deficit of primary care physicians, as we know, not only in Southern California, but all over the state and the country, that make doing nothing not an option. And so this has really changed in the time that I've been gone and come back, and that is, we were really focused on how many more lives can we manage, and hospital administrators go out there and try and contract with more and more physician groups so that we can have influence in caring for more people. But in the time that I've come back, we've got a lot more things to worry about now, and creating more value so that there's returns on your population health strategy, what you have to share with payers, what you have to share with physicians for performance, the cost of doing business. And then as we manage people more effectively, while we're still somewhat of a fee-for-service country where we've got a high amount of fee-for-service patients and we've got more moving into managed care and capitation strategies, that there's a reduction that we'll see in those fee-for-service patients over time, the volume of them. And but a positive thing is, as we manage more groups of people and engage in more population health strategies, that we'll be able to keep more people in our system. And so one of the comments that, I can't remember who mentioned it, is hospitals are thinking about developing narrow networks. This year, Dignity Health took a big leap, and it was a leap because not because every other health system's been doing it, and we're a slow adopter, but that we calculated the costs of when you are buying care from another organization. You don't know the basis for those costs. You don't know how to manage them. And so we adopted a narrow network strategy that rolled out January 1st and it's fraught with lots of problems. We're realizing really quickly to offer a product to your employees, which is our test market, that we don't necessarily cover all the bases and so if there is an esoteric specialty, we might not have it at my hospital, and so I'm hot on the trail of trying to fill in all our gaps so that we don't outsource care to other hospitals and have to buy it at a cost that we don't know what that is. But all those pieces together, that's keepage, gives us the impact on operating income. The basis of this slide, I'm going to be real quick about it, is that we assume that there are clinical saving opportunities for us. If we can manage care better in our hospitals, and we know the cost basis for them, we have a way of doing things in each service area, and we focus our target not on just providing episodic care, but on looking at how we manage patients with chronic diseases and other complex care, that we think that it's worthy of us spending some time to develop some strategies in each market to do that. So to sum it all up, while each market has our own strategies, we did find that there were some common key levers in some of our what we think will drive success. And one of those is something that we're thinking about now. Should Dignity Health develop its own health plan? And we call that getting closer to the premium dollar, because if we're closer to the premium dollar, we know how to manage it better within our system. And we believe that if we go down this line of whether it starts with a narrow network, whether it goes to developing a product within another health plan, or eventually developing our own, that we might have an opportunity to manage care better and at a different cost structure. The other opportunity is moving people from less valuable lines of business to more valuable lines of business. And all that means to us is that where we try and develop more coordinated care and can develop more clinical savings, we try and shift people into those products that we think we can optimize them so we can reinvest them back in our system. The absolute thing that I think rings true for every hospital CEO is, and we can never underestimate, is investing in physician alignment activities. And we know that our hospitals sit empty without them, or can be poorly utilized without their engagement. Their engagement on how we use information, their engagement on how we use pharmacy, on standard protocols. So we are committed to that, and that was another key finding that rang true for all of us, that there is a continual drive and a trend for us on reducing our cost model so that we can continue to deliver value, and that we have to, I think Sarita had this in her slide, look at alternative levels of care, and Roland mentioned his too with Adventist, that they're looking at other vehicles in a lower cost environment that you can manage care so that you can coordinate and add value to your overall performance of your system. That's it.
Thank you so much.